Welcome to Summit PT Podcast, your guide to recovery, performance, and wellness. I'm Dr. Kevin Koska, a doctor of physical therapy, and today we are here with Dr. Hayley Davis, an occupational therapist. In this episode, we are going to learn the differences between occupational therapy and physical therapy. We're also going to be discussing two of her niche programs, a Driving Rehab program, as well as her low vision program. In the Driving Rehab program, we talk about different adaptive strategies as well as different techniques that an occupational therapist would use to help somebody that is no longer able to drive or is having a hard time driving, and determining if there are solutions so that they can get back behind the wheel and regain their independence. We're also going to be discussing that low vision program and learning about different adaptive strategies that you can utilize out in public as well as in your home. And again, discussing some of the different techniques that an occupational therapist would utilize inside the clinic to help somebody with a low vision dysfunction. Stay tuned and hope you enjoy the show. So welcome, Dr. Hayley Davis.
Thanks for having me.
Absolutely. So I've been really excited about this interview. I've been talking to some of my OT friends outside of Summit and out in the community, and I hear this often from a lot of patients. Could you go into a little more detail about what is occupational therapy, one, and then two, what is the difference between OT and PT?
Sure. So occupational therapy, as I like to describe it, is a balance between science and art, and being able to combine the two to make you as independent as possible throughout your daily life, whether that be your daily activities of just caring for yourself or your hobbies. So it goes down to what you need to do and what you want to do, and just making sure that you can do all of those things independently as possible.
I've always heard it broken down like anything that you can end with an ing. Is that true? Fastening, buttoning, eating, those types. Is that true? First of all.
Yeah, bathing, dressing, grooming, toileting. The ing is a very good description.
Okay. All right. And is there any difference between like the goals that you set between OT and PT? Any differences between like the patient populations, or even how about treatment approaches?
There's a lot of differences. So a lot of the time people like to describe it as OT does upper body and PT does lower body, which isn't really true. We both are trained to do the whole entire body, but it comes down to the goals. So physical therapy looks at how the body's moving and is it moving functionally, while the OT professionals are going to partner with the PTs to actually make that movement of the body functional in their tasks. So our goals are going to look a lot more like patients going to be able to independently dress themselves by 2 weeks. In an outpatient setting, they do have a lot of similarities because we focus a lot more on the underlying factors like range of motion, strength, and all of those things, but we always try and tie it back to a function. So a common way that I see a difference is when I work with workers' comp. I'm working on a specific task of their environment and of their work goals, and I'm tying it specifically to that task, whereas a PT may just look at the range of motion or the strength aspect of it.
So, for example, maybe somebody at like Amazon that is having to go get packages and moving it back and forth, and they hurt their elbow. What would that look like from an OT perspective? I know what it would look like from a PT perspective. I'd get their range of motion back. I'd get their strength back, obviously while working on pain and reducing swelling, and then I would try to return them back to work, whatever it is that they would need to be able to do. Would there be any difference there between PT and OT in that particular situation?
With a more orthopedic injury like what you're describing, it can look very similar. We like to use activities, whether it be occupational as a means or occupation as an ends. We are looking at the activity that they're trying to get back to, and we will practice different aspects of that activity. So we might break it down to, all right, let's just pick up a weight and just stand there for a minute. And then we'll move on to, all right, let's bring it to waist height, and then let's lift it overhead and gradually increase the complexity from there.
Okay, I get it. And maybe that wasn't a great example, but I do see a lot of the programs that you do, you're always doing something different than the PTs are doing whenever I see you working with patients and PTs working with patients. So I know there's definitely a distinction between the two. Are there any types of conditions that you typically see as an OT versus what a PT might see, or are they always, you guys always, or are we guys always working together?
I like to see us work together a lot of times because we can get those goals met so much faster when we work together. With PTs working on the mobility and strength of the body while I work on the functional task. And it might be that I'm adapting the task in the meantime while they're healing, and PTs are getting that healing done faster. And then I keep them independent. But there's also differences. Whereas if someone doesn't have both, some conditions that I see that PTs may or may not see is I do a lot of neurological conditions. While PTs are definitely capable of doing it, I look at a lot of sensory integration, whereas from what I understand, PT doesn't do a lot of sensory integration and the emotional component of it, of what's their stress management looking like, and how is that impacting their healing? How's their sleep habits impacting their healing?
Absolutely. Yeah, we all know that nutrition and sleep definitely impact healing, certainly. Something you said earlier was about the adaptive function that they may need, and I hear that a lot when I'm talking to OTs. There's always something about how to your minds work differently than at least what my mind works with, and how you can utilize a tool if it's at work or at home, if it's a spoon, if it's a pencil, and how you can make it adaptive for them to still be able to use while they're injured. Mm-hmm. My mindset is always just like, well, we got to let it heal a little bit. But I love the OT mindset that, no, we can get you a pencil that'll still work for you so you can do X, Y, and Z, or we can get you a spoon, a certain type of spoon, so you can still eat while you're healing. So I love that. I love that about OT, and I think that's very, very creative. So going into more specific conditions and more specific niches. So something I brought up recently to a friend, and I didn't know anything about it, and it is driving rehabilitation. Can you tell me a little bit about that? Like, who benefits from that?
So a lot of people that benefit from driving rehab are people that have neurological conditions, whether it's an incident that does one major hit like a stroke or a TBI, and then they have a healing process afterwards, or it can also be neurological conditions that are progressive like Parkinson's. People also benefit from it with just age decline. As we grow and age, our bodies change and adapt to the environment and the stimulus that we give it. So if people are sedentary, like a lot of America unfortunately is, we get a lot of stiffness, we lose range of motion, and that affects our ability to turn our head, move our bodies, safely be able to see our environment, and then be able to respond in a timely manner. So any osteoarthritis, RA, broken bones, even for short term. And then the other conditions can be like amputations, so permanent changes of the body as well.
Okay. So we had a discussion previously on one of the podcasts with a vestibular therapist, and it related to some of the driving as well. And you mentioned even rotation of the neck, and she related it to limited rotation can also cause dizziness while driving, and you just mentioned it as well. So those that are out there listening, we also need to think, as we do age, we do lose range of motion, and that's why it's so important to keep up with your movement, keep up with exercises so that you can still rotate, so you can get in and out of the car and still be able to drive. What are some of the areas that you, and this may be too general of a question because it sounds like the driving rehabilitation is very customized to that particular individual, but if you are to just kind of generally think about it, what are some of the key areas that you assess? Is it cognition, vision, their physical, what we'd say physical impairments, lack of range of motion, lack of strength?
So for any individual that comes in for driving rehab, we're going to look at their physical abilities. So that range of motion, strength, coordination, reaction speed.
Reaction speed, that's a big one.
Yes. Then they have the cognitive perceptual skills. So is their depth perception messed up? Is their visual acuity to be able to read the signs and be able to know what's coming on? And then also like visual field. So if they've had a stroke and have a visual field cut where they might not notice that they aren't seeing the left side of their environment. Their mind is just filling in that gap. So we have to assess that so that we know to teach them visual scanning techniques or get mirrors added to the vehicle to improve their vision of their environment.
That's another, I can go down so many different roads when you start talking about that. That's when I see you in the clinic and having all these cool different toys out playing with learning depth perception and reaction time. But you also mentioned the different mirrors, so that brings up other types of adaptive strategies, which we talked about earlier. What other types of adaptive strategies are there for a car? I'm just trying to think, funny story yesterday. I'm helping my mother-in-law I got a car that's raised up a little bit, and she wanted to get inside of it. So I'm thinking, man, what do I got to get out a ladder or a step ladder or something like this here to help get her in and help get her out. I just kind of muscled her up and muscled her down.
Yeah.
But talking about adaptive strategies, what type of, and I wouldn't recommend doing that for the layman out there. You're going to be in the clinic for a hurt back or something. But adaptive strategies, can you go a little bit more in depth on some of those for your driving program? So
I can recommend, I don't have the Certified Driving Rehab Specialist certification, so I can't do on-road assessments, but I can, based on their skills that we see in the clinic, I can make recommendations that I would then forward on to this therapist that would do the on-road assessment.
Okay.
But we can look at mirrors, the seating posture, so anything like lumbar supports, or if someone has an amputation, we can, on the right leg, do a left pedal. There's modifications for steering using pedals on the steering wheel, also spinner knobs if they have an amputation on the arm or hemiplegia from a stroke. And then using head controls for turn signals and things like that. If they have one hand that's unable to help operate the vehicle while the other hand is steering, they can use head controls as well. There's lots and lots of options.
Yeah, that sounds like it. I always see, I've been injured in the past and haven't been able to drive, and I mean that's just for like 2 to 3 weeks. And I can't imagine not being able to go through that process and go to the grocery store or run errands, especially for somebody that is starting to age. So keeping them independent and as long as they can has got to be very important for other family members, as well as their own ability to socialize with others too. Have you had any recent, let's say, success stories with anybody that you've been working with from a driving rehab standpoint that you could touch on?
Yeah, I had a woman that was unable to drive after a traumatic brain injury. Her biggest limiting factors was her vision and coordination. So we worked heavily on her coordination of her right hand, being able to maintain an outstretched arm, being able to control the steering wheel while she's turning, and then worked a lot on visual skills, oculomotor exercises, being able to scan her environment and focus on a point while having distractions in the environment. She, after, I believe it was 3 weeks, she was able to return to driving independently, whereas she was having to have a friend actually drive her to appointments and anything that she needed.
And I'm sure she complained about how much of a burden she probably felt with some of her friends. 'Cause I know I would they'd probably do it for a week, and then it'd probably get a little old after a while, just continuing having to ask people. So
she was very excited. It was the first thing she told me. She was like, "My doctor cleared me to drive."
That's great. And so more kudos to you for helping somebody become more independent and be able to keep their wings a little bit longer so that they can continue to socialize and live a happy life. Yeah, so moving on from driving rehab, you also have a program called Low Vision Program. Can you tell us about what Low Vision Program is?
So low vision is considered any permanent changes of the vision that is impacting their visual field or visual clarity. So diagnoses that this could include is macular degeneration, glaucoma, diabetic retinopathy, or even visual field changes like I touched on with strokes.
So is it they can't see far away, they can't see close, or is it just all of the above?
It could be all of the above.
Okay.
I've had one person where...
Cloudy, like glaucoma?
I was having someone where their visual field should be out here, and then when I assessed them, their visual field was here. And so I had to teach them scanning techniques to really pay attention to their environment. They were talking about running into objects or misplacing things. And so we worked a lot on visual scanning techniques because a visual field deficit isn't something that I'm going to be able to give back to them.
Sure.
So it's...
If so, I'm signing up.
I know, right? I would love it. So we do a lot of compensatory strategies and adaptive tool training with low vision.
What are some of those adaptive tools? I'm into all these adaptive tools that you guys talk about.
So adaptive tools for low vision can be something as simple as really high contrast tape, taping it on different environments, like on a step, so they can see the difference in the height and know that there's a change in height coming so that they don't trip and fall.
So like a yellow piece of tape on a stair or something. Okay.
Other things can be large print objects. A lot of people use large print phones, clocks, or they'll really big print word games and things like that.
You blow their phones up really big so that they can see the text messages.
Yeah.
I think that's my next step, is making my font 20.
One of the best tools that people have in their pockets is actually their phone. The phones nowadays have so many accessibility features on the phone for low vision. Blowing the screen up also has a magnifier on it, so you can use it to read a book if it's low print and just blow up using the magnifier on your phone.
I think I've seen that option on there scrolling through there. It's funny that you say that now. I'm kind of putting it all together.
Yeah, the phone has become such a great tool for low vision, and then working with people that are blind using text-to-speech options on the phone. So you just tap something and it reads it to you. I have one gentleman that he actually has his text messages just automatically read unless he turns it off. That way he knows who it's from and what they need, and if it's something he needs to respond to immediately.
That's very smart. So I mean, that kind of tells us about the role that technology plays. I mean, we have our phones. Anything else cool that's out there that I just am not aware of and oblivious to? It seems like you guys use it all and have thought through a lot of this.
Yeah, a lot of the coolest technology has actually just been disguised as technology used for everybody. So a lot of the watches, a lot of the pill organizers that can talk to you, and then just organization skills and mobility techniques that we start to teach everybody as they age, are heavily used with low vision.
That's awesome. So you mentioned the gentleman and him being able to use his cell phone for the text messages. Any success stories that you've had recently? I always love to hear about the success stories. I read them on Google all the time and love to hear about all the good works that we're able to do for the community, but I always like to hear it from the therapist's point of view as well, because we wear our emotions on our sleeves when we see these patients, and we always want them to get better no matter what. So I love to hear it from the therapist. I mean, Don't get me wrong, I love to hear it from the patient side of things, but I also like to hear it from the, because you see so many people.
Yeah. Well, the gentleman that I referred to just a moment ago, he has caregivers that take care of him, and his caregivers have actually come up with some different things that he doesn't necessarily want to talk about, but it would make their life easier and him happier. So we've worked on working with a cane, and like the red and white canes that for mobility, using that in how to navigate environments. He went from always being led around in the clinic, not using his cane, not really wanting to work with it, to now he gets up and goes to the bathroom by himself when he's in the clinic. And then he's been more independent with getting in and out of the car, because he can see not see what's going on, but he can feel his environment a little bit better, and he's more familiar with the ground around him.